folks, a very warm welcome to our Young India Intensivist webinars. Today is an international faculty webinar, and it is my great honor and pleasure to invite Professor Antonio Torres to our webinars today. Professor Torres is a professor of medicine at University of Barcelona and a senior consultant in the Department of Pulmonology at Hospital Clinic de Barcelona. He is globally recognized as an authority on respiratory infections, ARDS, and critical care management. With 1250 publications and an H index of a great number of 127, Professor Torres is one of the world's most cited researchers in pulmonary critical care. He has been honored with European Respiratory Society Lifetime Achievement Award, and his work in pulmonary critical care has changed practices all over the world in the ICUs. I welcome you, Professor Torres, sir, and it is an honor to have you with us. And the topic for today is community-acquired pneumonia, advances in pathogenesis, diagnosis, and treatment. Welcome, sir.
Thank you very much for this invitation. It is an honor to give this conference today for the young intensivists, and I will talk about community-acquired pneumonia, trying to share the important results from other researchers and our own research. So thank you very much. I'm going to share my slides. Dr. Pejmanal proposed me was advances in pathogenesis, diagnosis, and treatment of community-acquired pneumonia. But I will make a special focus on several community-acquired pneumonia because we have several studies performed and several ongoing. These are my conflicts of interest. And let us start with this classification of pneumonia that we wrote in this Natural Review in 2022. The pneumonia can be classified in community-acquired pneumonia when the patients are not hospitalized and the pneumonia is acquired outside of the hospital. And the cutoff point is 1 month. This is important. Otherwise, they will be considered community-acquired pneumonia. Hospital-acquired pneumonia is the incubation of this respiratory disease, at least 2 days of the requirement is 2 days of hospitalization. And then ventilator-associated pneumonia, that is the hospital-acquired pneumonia that occur after 48 hours of endotracheal intubation and mechanical ventilation. Another important group is aspiration pneumonia. I'm not going, see, I would refer to aspiration pneumonia later on because it's very frequent in the community and it represents 20% of the cases of community-acquired pneumonia that require hospitalization. And finally, I don't know if this is true now, the healthcare-associated pneumonia, the HCAP, it has been seen that HCAP is probably not a good term, but we can discuss this later. So the incidence of CAP is 3 to 25 per 1,000 cases per year per individual. 30% of these pneumonias will require hospitalization. ICU admission and the overall mortality is 8 to 10%, depending on the several factors, the comorbidities, the age, etc., etc. And the incidence of VAP is 5 to 8 cases per 1,000 days of mechanical ventilation, and the crude mortality is the 30%, but attributable mortality is 14%. And since you asked me to talk about pathogenesis, last year I did a talk on that for an European Respiratory Society seminars, and let's just start with it is more frequent. The most frequent process of development of pneumonia is the first colonization. So microorganisms enter the nasopharynx after shedding from a colonized individual. Pathogens can spread between individuals via direct or indirect contact, droplets, and aerosol. And the transmission success depends on many variables that include environmental conditions, gathering of people, host factors such as the distribution of pattern recognition receptors in the epithelial cells of the airways. This point is very important. Once in the nasopharynx, bacteria escape from mucus and attach to the epithelium. One of the main mechanism to evade the host clearance is the expression of host mimicking or antigenic varying molecules and molecules that imitate the structure of the host molecules or can vary their antigens to avoid recognition by host immune cells. Microorganisms aid entry to the lower airways through inhalation or less frequently by pleural seeding from blood. And then the selection of colonizing mutants that can evade immunoclearance is considered to present infection. As you can understand, there are many comorbidities, especially those comorbidities related to respiratory diseases or smoking that can evade this process. Finally, infection occurs when the host defenses are impaired or there has been exposure to highly violent microorganisms or a large inoculum. These 3 points are really very important. So not everybody will develop a pneumonia when there is colonization and the evasion of the control mechanism. Loss of barrier integrity and impaired host defenses to the complex interactions among anatomical structures, microorganisms, and the host immune system. An important concept is that the lungs are not sterile. And we know for several countries, for several publications that using the molecular techniques. And instead, they harbor a unique microbiota with more than 100 different taxa. When there is a modification for several reasons of this normal microbiota, then this microbiota, call it normal, is replaced with microorganisms, pathogenic microorganisms that can affect the lungs. Importantly, bacteria present in the airways increase resistance to pneumonia through the NO2-like receptors and induce to release granulocytes macrophage stimulation factor. So as you see, it is not an easy process, and it is modified, but important risk factors by age, by immunosenescence. But this is in pneumonia can occur. It is very frequent, but it's difficult that can occur without the impairment of the host defenses. Although I have to say that the large inoculum that occurs sometimes is very important as well. Some of the pneumonias are due to the inhalation of the aerosols. And this is the case of Legionella, for example, that even surpass the normal mechanism. And the Legionella pneumophila occurs because there is a large inhalation of inoculum that it is in the droplets that you inhale. Look at here, for example, the size of the droplets are very important. If they have more than 100 microns, they go down to the floor. And then depending on the size, will produce or not an inflammatory process. More than 10 micron or 5 to 10 micron, then impact in the large bronchi and do not produce an inflammatory effect. Only those that are less than the 5 micron reach the alveoli and produce the reaction of the macrophages. So colonization is the first stage. First, we review that. Aerosol inhalation is another issue, and it's for very specific microorganisms, such as Legionella, for example, viruses as well. And it is important, I can skip that one, and then after there is pneumonia and the microorganisms reach the alveoli, there is an initiation process triggering the phagocytes. There is an amplification. There is the defense of phagocytosis, and finally there is the resolution. We can divide this in 4 phases. Now let's move to the etiology of microorganisms that produce respiratory infections. And if you look at this information published in 2024, a couple of years ago, about the pathogens, and in this column, or in these columns, in these files, you can see the age here in this axis, and the number of deaths. As you can see, Streptococcus pneumonia, according to this epidemiological study, is the most important, the most frequent microorganism. And the most lethal as well, both in children and in adults. For that reason, it's very important to prevent against pneumococcal disease and pneumococcal pneumonia. Of course, viruses are important and probably will be more important within time because now we have molecular techniques that can detect several viruses just having samples of the nose or the oropharynx. This is important. The case of bacteria is different because the new methods are not so easy to be interpreted. But again, my message here that the strep pneumonia is still the most important and the most detected as well. Of course, more and more we have different microorganisms such as another cause community-acquired pneumonia are not very frequent, but the Enterobacteriae, Pseudomonas aeruginosa, Acinetobacter baumannii, and polymicrobial, we are seeing more and more this in the community because we have more and more patients with risk factors or immunosuppressed. Let's move to the severe community-acquired pneumonia. This is a paper that we published in 2018 in PLOS ONE, and this is before COVID. And we divided the patients according to the use of invasive or non-invasive mechanical ventilation in the ICU, in the respiratory. Again, strep pneumonia was the most frequent and important, but in that series, Staph aureus and Pseudomonas aeruginosa were important as well. Very importantly, polymicrobial, both in mechanical ventilated and non-mechanical ventilated, was the cause of an important percentage, 14% and 24% respectively. And usually polymicrobial means a virus plus a bacteria, the most frequent case. And the mortality of these patients is higher compared to those that have monomicrobial pathogen. The mortality of this series was really very high. I think that the mortality has decreased now, and we need good epidemiological studies now about etiology after COVID and after the implementation of the molecular techniques. But look at here, at that time, 2018, the combination, if the patient was mechanically ventilated and had shock, the mortality was really very high. 38%, this is an acceptable mortality, probably now. We published this paper this year in this journal, and the period of a study was 2023 and 2024, and we compared the etiologies of monomicrobial versus polymicrobial. This was patients with severe CAP and non-severe CAP admitted to the ward. And you look at here, again, strep pneumonia is the most frequent, probably because we detect frequently in the cultures. We have at our disposition the urinary antigen that we do not have in other pathogens except Legionella pneumophila. But look at here the viruses, the percentage of the viruses. I am sure that viruses are probably now the second or the third cause of community-acquired pneumonia, both as a single pathogen or with bacteria, which is a result of a co-infection. Let's move to the definition of severe CAP, because today my talk is focused in severe community-acquired pneumonia, and you can see here the 2007 Infectious Disease Society of American Thoracic Society criteria for defining severe community-acquired pneumonia, and still we are using that. A practical definition could be those patients admitted to the ICU, but this depends on the resources of the hospital, resources of the country, and the selection criteria that some hospitals have due to several things, including economical restrictions. Of course, septic shock with need for vasopressors and the requirement of mechanical ventilation, it's clear that this is a patient that has to go to the ICU if possible. And then we defined it in 2007, some minor, I think now minor criteria. If the patient had 3 out of 9 minor criteria was defined as severe community acquired pneumonia. I think that we have now new elements and variables that could be added. But for example, here, just an example of that not everything is so clear. Now, multi-lobar infiltrate. What is the meaning of multi-lobar infiltrates? Is 2 or more infiltrates in the chest X-ray. But we look at this in our database, and multi-lobar can be bilateral or unilateral multi-lobar. And this was published by Adamanti Aleapico in 2016 in the European Respiratory Journal, and we found that the mortality was only associated with bilateral. And this probably should be revisited. Lymphopenia is another easy parameter that could be added. For example, in this paper published in eBiomedicine by our group in 2017, we defined lymphopenia, or we found the threshold of 724 lymphocytes per millimeter. And these patients had to fall mortality risk. And this was validated in patients with CAP, with severe CAP, and also by other institutions. This is something very easy to take a look, because every patient in the world has at least a blood count, and you can look at lymphocytes. Another reason, but important, I think, factor is eosinopenia. And we found very recently this year in this publication in Pneumonia, the Pneumonia Journal, that eosinopenia is a risk factor for mortality in severe community acquired pneumonia, and other very recent studies in chest have confirmed that. So with this threshold, lymphopenia and eosinopenia probably could be used to the risk factors to define severe community acquired pneumonia. Let's move to the molecular test, the new test. So probably you are doing the same. We are managing pneumonia as a syndrome. This is the reality. We have some clinical diagnostic criteria. There is a diagnostic uncertainty. We start with an empirical treatment, and then we fail, or we don't fail as regards the initial antibiotic therapy. Now, with the molecular test, what we want is the following. Then to detect all the cases of pneumonia very clearly, and to use perfect tests, which is not true, and then to find a positive pathogen, and to start to have a diagnostic certainty, and then to start as soon as possible an treatment, which is called treatment position or pathogen target antimicrobials. We still are using empirical antibiotic treatment, and sometimes the patients have no pneumonia. Sometimes they have a pathogen that is not covered by this empirical treatment according to the guidelines, etc., etc. Well, this is the same, but we published this review article this year in Intensive Care Medicine, and it's reflecting the same. Look at here what is telling us the figure is that the microbes take 48 hours to grow in the plates, and then there is always a delay, and to detect the mechanism of resistance. And what we want is what you see here: amplification, rapid detection, and potential antibiotic changes as soon as possible. What is the most used in clinical practice is this commercial multiplex polymerase chain reaction panels for, in this case, was for hospital-acquired pneumonia, but they can be used in community-acquired pneumonia. This is because the manuscript referred to hospital-acquired pneumonia. And we have the Filmarine Pneumonia Plus and the Univero Pneumonia platform. And the methods that these platforms use are here. They detect 18 bacteria and viruses, and here 20 bacteria and 1 fungus. They are not the same exactly, comparing the two platforms. And the majority of viruses causing disease in the community, a lot of bacteria, and some resistant genes. This is a problem. There are some bacteria that are not covered, and some resistant genes, for example, for the quinolones that are not detected or are not in the platform for technical reasons. I think there is no an ideal study, but the ideal study to be performed should be randomized to standard microbiological methods. Second, blinded if possible, which is very difficult, and I don't know if this is ethical, excluding bad quality samples. This is not done in the studies, the majority, using BAL, preferring BAL, and including patients with and without prior antibiotic treatment, but this allows you to see the sensitivity of the new platforms compared to the cultures, and with a well-designed intervention protocol. So up to now, there is no evidence that the systematic use of these methods decreases mortality, changes the outcomes. The only thing that is seen, and look at this meta-analysis published this year, and eClinical Medicine, is that the duration, the number of antibiotics used, and the antibiotic duration in this meta-analysis was lower using the molecular point of care testing compared to the microbiological standard cultures. But this is important. But still, we need a very good study. Importantly, this is not correlation, is a study that is telling us that only the bacteria detected in the culture with quantitative cultures 10 to the 5th or 10 to the 7th, no, excuse me, 10 to the 5th or 10 to the 6th is good, it is good correlated with a molecular testing with a positive testing. So otherwise, it can detect colonization. So it would be nice to have more studies with quantitative cultures, microbiological cultures standard, comparing to the molecular test. To me, the benefits of using rapid molecular techniques, especially in the severe CAP, is first, there is an increased sensitivity even in patients treated with antibiotics. This is clear. And is the inverse when you study the standard micro methods when there is prior antibiotic treatment. You have very early results, no doubt. Favor to more initial adequacy of antibiotic treatment, decrease in the use of antibiotics, and provide rapid information about some resistant genes. Let's move to the empirical diagnostic treatment. I said before that, of course, what we want is to go to adequate and targeted initial treatment. This is still not possible at all, complete in all patients. But look at here, and let's go to the antibiotics used in severe inpatient pneumonia. These are the 2019 guidelines, ATS, IDSA, that were updated this year only by ATS in 2025 by Evans et al. And if you look at here, still a beta-lactam plus macrolide or a beta-lactam plus a fluoroquinolone, levofloxacin or moxifloxacin, is the recommendation for the empirical treatment of severe pneumonia. Look at here, because not everybody has that, but levofloxacin, they recommended 750 milligrams or moxifloxacin 400 milligrams. Not everybody, or every country has the formulation on 750, and there is a current mistake that they use levofloxacin using a single dose of 500 milligrams, that it is not enough to cover some microorganisms according to the PK/PD studies. Or you use 750 or 500 every 12 hours for severe community-acquired pneumonia. We published these guidelines in the 2000, excuse me, this is moving, in 2023 in Intensive Care Medicine and in European Respiratory Journal. And one of the questions about initial empirical antibiotic therapy is, could the macrolide or a fluoroquinolone be used as a part of combination therapy to reduce mortality and adverse clinical outcomes? So the beta-lactam is clear, but what about the other antibiotic? And we suggested the addition of macrolides, not fluoroquinolones, to beta-lactams as empiric antibiotic therapy in hospitalized patients with severe CAP. Conditional recommendation, very low quality of evidence, because indeed there are not good randomized studies. And in this meta-analysis that belonged to the guidelines, we look at the length of hospital stay, mechanical ventilation. In these studies that were the only randomized or post-hoc analysis of randomized clinical trials, and we found that there was a decrease in the length of stay and a decrease of the need of mechanical ventilation when using macrolide versus fluoroquinolones. This is in preparation. The leader of this study is Evangelos Giamarellos Bourgoulis, and if you look at here, using all the observation, the majority of observational studies, of course, the resultant was a decrease in mortality, but we are still working in that study. So our recommendation is to use macrolides in combination to beta-lactams. But what macrolides? This is important. Evangelos Giamarellos Bourgoulis published this observational study and in patients with severe community-acquired pneumonia, and they look at it as a primary outcome, the 28-day mortality. And you look at here, the results were better using clarithromycin compared to azithromycin. Not all the countries have IV clarithromycin. And why is that? Then we have to go to this study published in Lancet Respiratory Medicine 2024, the AXE randomized trial performed by the group of Giamarellos Bourgoulis. These were the patients that were included. They were patients mainly in the ward, but with some type of severity. Okay, and they compared the standard of care plus placebo and the standard of care plus clarithromycin orally 500 milligrams BID. And what they find? Well, these are the points or the days that they studied the different parameters. So the positive response was considered in that study by a 50% decrease of respiratory severity symptom score on day 4, 72 hours after start of treatment, or a 30% decrease of SOFA score on day 4, or 80% decrease of procalcitonin on day 4. And they found, according to the definition of the primary outcome, that clarithromycin was the patients that received clarithromycin achieve more frequently all these parameters that I explained to you. Why is this? Well, probably because the immunomodulatory effect of clarithromycin compared to azithromycin, and for example, here, 25% decrease of baseline interleukin-10 or undetectable interleukin-10 in blood. This was more frequently achieved by clarithromycin in the clarithromycin arm, and increasing the ratio interleukin-8, interleukin-10. And the same results or similar results were better in the clarithromycin compared to the other macrolides. Let's move now. Something that is important is the duration of antibiotic treatment. So now it's clear to us that we have to use the combination of beta-lactam plus a macrolide then that clarithromycin seems to be better according to the study of Jamarellus burbulis, and there are other papers about the trial that are coming showing the same. And what is the recommendation of the guidelines to shorten antibiotic treatment? In the world, the ATS guidelines, in the updated TWACE guidelines, they used the term clinical stability in community-acquired pneumonia, and you can see here the different variables such as apyrexia and the cutoff points, heart rate, respiratory rate, saturation, systolic blood pressure, normal mental status, ability to eat. Okay, that's fine in the world. And let's use this paper because I think it's important. This paper published in Lancet, they discontinued. You have the algorithm here of the design of the study. They did not include patients in the ICU, but they discontinued beta-lactams after 3 days of treatment or not in the other arm, according to the achievement of clinical stability. And there were no difference in the outcome. These are the methods and the period of a study. This is not important. We can discuss this later. Okay. But according to the ITT and the per protocol results in different subsets of populations, for example, according to age, the PSI score, and other variables, there were no difference in the outcomes comparing this procedure of stopping antibiotics after clinical stability. The problem in SCAP, I can skip this one as well. No, these are my suggestions, sorry. The added value of this study, they provided clear evidence from a non-inferiority double-blind randomized control trial that we can safely discontinue beta-lactams treatment after 3 days in the patient's clinical stability. Can this be extrapolated to severe CAP? Probably not. You will see my question later on. My suggestions for adult outpatients with CAP who reach clinical stability, I suggest 5 days or less of antibiotic treatment. For adult inpatients with non-severe CAP who reach clinical stability, I suggest less than 5 days, minimum of duration of 3 days. For adult patients with severe CAP who reach clinical stability, I suggest 5 or more days of antibiotic treatment. But the problem is this question. Are clinical stability criterion established in hospitalized patients extrapolable to severe community-acquired pneumonia patients under mechanical ventilation? And the answer is no. Nobody has done a study to define clinical stability in severe community-acquired pneumonia. Biomarkers. This was the question number 4 of our guidelines published in 2023 about the use of if procalcitonin can be used to reduce of antibiotic therapy and improve outcomes in comparison to standard of care not guided by serial biomarker measurements. And we suggested the use of procalcitonin to reduce the duration of antibiotic treatment in patients with SCAP. But this was a conditional recommendation of low quality of evidence. A review of the literature revealed no studies that specifically investigated the role of CRP, for example, and procalcitonin in limiting antibiotic use in severe CAP. The studies performed in the ICU included critical ill populations with sepsis from different organs. And we selected 4 studies because they included 40% cases of pneumonia. There are not studies only in patients with pneumonia. This is important. And these are the suggested research priorities. We need more in a very well-defined population of severe CAP. We have to use we have to do randomized clinical trials comparing the use of procalcitonin or the not using procalcitonin to reduce the necessary antibiotic treatments. Let's move to controversial question. And that was the question number 6. asks, does the addition of steroids to antibiotic therapy in a specific severe CAP community-acquired pneumonia populations led to better outcomes in comparison to when steroid therapy is not needed? Okay, in our guidelines published in 2023, we look at the studies randomized at that time, including patients with severe CAP, 4 or 5 or 6 at the time, and we found that in patients with septic shock, there was a decrease in mortality. And for that reason, we recommended to consider and to use methylprednisolone at that time in that population in patients with septic shock. Please remember that in patients with influenza, observational studies suggest that there is an increased mortality. So up to now, don't use steroids in patients with severe influenza community-acquired pneumonia. However, if you go and you review the trials that are ongoing now, you will see, especially in France, that there are several trials going on using steroids versus placebo in patients with influenza and severe community-acquired pneumonia. These studies are not finalized yet. This was our recommendation in patients with shock, but now there are some changes. Well, let's just start with the 2019 ATS-IDSA guidelines for community-acquired pneumonia, and you can see that they were against routine corticosteroids for severe CAP. But then after these guidelines, in 2022 and later on, there were 3 studies, 2 of them negative. This is a study from Gianfranco Umberto Meduri comparing low dose of methylprednisolone in critical ill patients with severe community-acquired pneumonia in veterans, American veterans population. The study was negative, but they used corticosteroids for 21 days, probably a too long period and we can exclude the harm of steroids. And this is probably the most important paper, the 2023 New England Journal of Medicine, comparing hydrocortisone versus placebo in patients with severe CAP. And this was published in the New England Journal of Medicine. And you can see here that there was a decrease in mortality, 11.9 versus 6.3 at 28 days, or at 90 days, 14.7 versus 9.3. This is important proportions. They compare hydrocortisone first a bolus, and then I think 200 milligrams every 12 hours. And in patients with severe community-acquired pneumonia, it was a multicenter study. After that, there was another study from the REMAP CAP platform that was negative. So controversially, the controversy still exists. Several meta-analyses are published, and this is one of 2023, published in CHEST, selecting patients with severe community-acquired pneumonia only, and the meta-analysis suggests a decrease in mortality as well, comparing corticosteroids to placebo. Smith and colleagues performed another meta-analysis called a data, using the individual data of patients asked to the different investigators. And what they found, because this is important, that the only factor that showed a positivity or a benefit of corticosteroids was C-reactive protein using this threshold of 20.4 milligrams per liter. The only factor found. So probably you have to think more in the inflammatory response plus the severity probably when using corticosteroids in severe CAP. We can skip this one. We performed some analysis in our model of our pig model of pneumonia. This was published last year, I think in 2025, yes, in Intensive Care Medicine Experimental. And we compare corticosteroids versus macrolides or corticosteroids plus macrolides in a pig model of Streptococcus pneumonia, and a porcine model. This are our piglets that are intubated. There are very difficult things that we have to do. We keep the animals alive, but with infection during 5 days in our ICU, piglet ICU, and we found the following. This is the Streptococcus pneumonia concentration in the lung at necropsy. And this is cefotaxime, ceftriaxone, azithromycin, methylprednisolone. And in the only set of animals that we found 0 colonies of Streptococcus pneumonia in necropsy was when using the combination of azithromycin plus methylprednisolone. There is synergy or not? We don't know. But in the practice, we always use beta-lactams plus macrolides, and then we decide to add or not to add corticosteroids according the level of C-reactive protein. This is our clinical practice management. We can skip this one. In immunosuppressed patients, be careful. You have to be very careful. There are not randomized studies in patients with CAP that they are immunosuppressed. And in this study published, I think, in 2026, so this year, was observational retrospective study in the patients immunosuppressed with community-acquired pneumonia that were treated with, in addition of antibiotics, they used corticosteroids. There was an increased mortality in several populations. So don't give to the patients immunosuppressed with severe CAP corticosteroids up to now. Other immunomodulatory agents, one of them is anakinra. This was published by the group of Jamarellos Bourgoulis. They selected this population of CAP or HAP patients, and finally they choose 30 versus 30, and they look at the primary outcome, the progression to organ dysfunction of 2 or more points by day 7 or death by day 90. And this is the study published in the Lancet Regional Health Europe in 2025. And they found, when using anakinra, blocking the inflammatory response, that there were decreases in mortality at day 28 and mortality at day 90, and this is a small subset of population. Maybe in the future, we'll have more clear in which population we can use anakinra. Multi-drug resistant organisms are not very frequent in the etiology of community-acquired pneumonia, but they are. And if they are causing pneumonia and severe pneumonia, they have to be treated differently. And the question number 7 of our guidelines was, does the use of a prediction score for drug-resistant pathogens lead to more appropriate therapy and improved outcomes? Mortality, treatment failure, duration, prolonged ICU stay. Well, there are several scores that probably they should be implemented now with molecular techniques, but these scores, and this is the resistance of CAP pathogens with potential clinical implications, the most important is this one. We developed this score, the PES. P stands for Pseudomonas, E for ESBL, and S for methicillin-resistant Staph aureus. All microorganisms that will need or would need different antibiotic treatment than the standard one, beta-lactam plus macrolide. Okay, and this score is the PES score. We look at that, and that was validated when this score with a very useful, easy variables to record: male, previous antibiotic use, chronic respiratory disorder, chronic renal disease, and at emergency consciousness impairment or fever or shivers. The area under the curve was 0.754, and with the score or 5 or higher, the prediction was around the 70%. I think that in the molecular platforms, what I would do in patients with risk factors is trying to perform rapid molecular techniques in good respiratory samples. Aspiration. I think this is my last section. So I said before that aspiration pneumonia is important. It is not well defined. Most of the clinicians, especially in severe pneumonia or admitted to the ward, give anti-anaerobic treatment because there is the belief that aspiration pneumonia is caused by anaerobic microorganisms. But according to the investigations, few investigations, now we know that probably anaerobes do not play a very important role in aspiration pneumonia. Which are the factors that have to use to suspect aspiration pneumonia? Well, a story of impaired swallowing that you can ask to the relatives, frailty, malnutrition, and poor dental hygiene. And then the recommendation is to treat the patients with the standard treatment that the normal patients receive. What we know for sure, and this is a systematic review that we published in 2025 in European Respiratory Review, is that these patients with aspiration or suspicion of aspiration pneumonia have a higher mortality and poorer outcomes compared to the non-aspiration population. Importantly, is what I said before. Studies performed decades ago, and mainly using transtracheal puncture, they isolated anaerobes because these patients had abscess or empyema. The studies from John Bartlett. But later studies found a very low proportion of anaerobes, and the current concept is that microorganisms causing aspiration pneumonia are more similar to those of CAP, including Staphylococcus and Enterobacterales, according to the risk factors. These patients have risk factors. The 2019 guidelines discourage the use of anaerobic coverage because it might cause more harm than benefit. New antibiotics in community-acquired pneumonia. You can find this in these BRN reviews 2025, and they are listed here. Mainly are lefamulin, omadacycline, delafloxacin, and pneumococcus. These two first, the ceftaroline and cetobiprole, they are in the market for several years, but they started be used in aspiration pneumonia some years ago. These are the really new ones. Here we can see the spectrum. All of them, importantly, are IV and oral. So you have the two formulations. They are approved for community-acquired pneumonia, at least these three ones. But in Europe, I think that only the delafloxacin, at least in Spain, the delafloxacin is the only antibiotic that uses. It is very expensive, and we need more investigations about these new antibiotics. But I think it's a good option because they cover most of them, gram-positive, gram-negative. They cover atypical stem, and some of them they cover Pseudomonas. For example, the delafloxacin, which is a new fluoroquinone. We can skip this one. It's very confusing. Okay. And let's move to complications of pneumonia. Short-term complications, the most frequent is sepsis, especially in severe CAP, of course, is a life-threatening organ dysfunction caused by a dysregulated host response to the pneumonia. This is the definition. And 40% of hospitalized patients with CAP have sepsis or develop sepsis. 5% of hospitalized patients with CAP have ARDS. Then the second important group of complications are the cardiovascular ones. 14% new or worsening heart failure, 5% new or worsening arrhythmias, and 5% acute coronary syndromes. The number three is the decline in cognition and functional status that can last for weeks and months. readmission of CAP patients is frequent as well. And the long-term complications that everybody is studying now are the cardiovascular increased risk up to 10 years after pneumonia. And the hypothesis is because there is a residual inflammation that impairs the circulation of the heart. Look at this lady. This was published in a newspaper in Barcelona, in Spain, February 3rd, 2023. This young patient, had a pneumococcal pneumonia with bacteremia, and he had amputation of part of the two arms and one leg. So be aware of these potential complications because they can be very important for the future of the patient. If you go to the guidelines, you will see a summary in this publication because some of the PICO questions that I mentioned today are summarized. This is Intensive Care Medicine 2023. Finally, this is the last slide. And sorry because I skipped some slides because I thought they were not relevant or I would need more time. Prevention. We are treating always about treatment, complications when the patients have pneumonia. But prevention is more important than to cure, to prevent. And look at here. Intensivist, we are not doing prevention. As a pulmonologist, we do some prevention, no? But smoking cessation, reduce the cessation of alcohol drinking, a good nutrition. Then remember that contact with sick children is an important risk factor when they are sick. This is impossible to solve, of course. Dental hygiene, physical activity, treat swallowing disorders to avoid aspiration pneumonia, and finally, very importantly, vaccination against influenza, now respiratory syncytial virus, pneumococcus, and COVID-19, and ensure the compliance with guidelines. Thank you very much for your attention, and I'll be very willing to answer any question.
Thank you, Professor Torres, sir, for a very wonderful lecture and updating us on the latest on pneumonia. So that's a complete update on pneumonia. I think the audience must have found it very useful. So I request the audience for any questions. Maybe I can just put up some points, sir, before that. So you mentioned about PCR multiplex, which is now available across the countries, across all ICUs. You also said we should not use PCR in all the patients. So in which patients do you think, sir, we should use PCR for pneumonias in the ICU?
I think that you have to probably to use PCR in all severe community-acquired pneumonia patients because you want to be sure that the antibiotic treatment you started is the adequate, but be aware that if the sample is of bad quality, this can be followed by misinterpretation. So colonization is frequently in intubated and mechanically ventilated patients. You know this very as well. For viruses, if you find a virus, there is a virus there. But for bacteria, be careful. Be careful. Use BAL preferred for the sample if the patient is intubated. Okay? And then discard colonization. And in parallel, you perform the cultures to confirm 48 hours later that these cultures will fit with the rapid technique. But I would use in all patients if possible.
Thank you, sir. So then you mentioned about viral pneumonias. Just now also you said, and you have shown the etiology, and they're the second most common etiologies after strep pneumoniae as per the chart that you had shown. So now again, sir, there can be viral colonization. The patient is coming from the community, admitted to the ICU, and is sick with pneumonia. He may be having a viral etiology, and viruses can also colonize. So how do you now diagnose viral pneumonias? Do you use some kind of a colony forming unit per ml or cycle threshold or just the presence? Can you just elucidate, sir?
Well, as I showed before, a positive uh, mm, rapid technique using the platforms, no, means that it is well correlated with a quantitative culture of 10 to the 6 or 10 to the 7 colony forming units per milliliter in the sample. So, meaning that the number of DNA copies is correlated with the high bacterial burden in the sample. So, if the sample is good quality, that means more than 25% of polymorphonuclears and less than 10% the epithelial cells. Okay, I think that you can rely on that. And even the technique is more sensitive. But if the sample is not good, you can detect simple colonizers. And this is the problem. And a lot of studies that I reviewed, the majority of them do not or did not use the determination of the quality sample. This is a basic concept that all microbiologists are doing to accept or do not accept a sample for processing. This is my major advice.
Thank you, sir. So then, supposing you are diagnosing viral pneumonia, and of course, commonest is influenza. There is some coronavirus also now, but there are many other viruses, and there are no real studies for treating these viruses, which can cause severe pneumonia. In fact, even pneumonia going on to the ventilator. And but we do have antivirals. There are anecdotal reports for various antivirals for these viral pneumonias which may be causing severe problems. So, should we go ahead with the use of these antivirals in these confirmed viral etiologies for severe viral pneumonias?
Okay, well, to my knowledge, there are a lot of antivirals that ongoing studies. This is one hand, but the only influenza and COVID-19 uh, have effective treatments. In case of influenza, we know, according to the literature, that you have to give the neuraminidase inhibitors the first 3 days, otherwise it isn't clear if the outcome. But of course, that you have to continue if you detect influenza A or B. And then for COVID, it's the same. You have to give the antivirals approved. And to my knowledge, the other viruses that can cause pneumonia, and here is metapneumovirus, respiratory syncytial virus, adenovirus, and other viruses, even rhinovirus in immunocompromised patients, they don't have antiviral treatment specific.
Okay, thank you, sir. So then about the pathogenesis, just a little bit. So the breaths that we take in, so so the air we breathe in. So in 1 minute, we are taking in around 15, 16 breaths or normally. So how many microorganisms are we inhaling in terms of microorganisms? The bacteria, viruses, fungi spores. It's not sterile, right? The air that we breathe in normally.
In which situation do you refer to?
Sir, in if I'm sitting in my room, is the air that I'm breathing?
In your room, of course, and walking in the street. And so inhalation of microorganisms is one of the frequent sources of infection in the human, and we are exposed to that, and in the circumstances that I described. So my recommendation, and for example, I do that to visit my patients. You should use more mask because now we lost the fear of respiratory infections because we win the battle of COVID, more or less, no? And we are not using mask. But in crowded situations, in the plane, or when visiting your patients in the ICU, you have to wear mask. I think that the mask is an important prophylactic preventive measure.
Thank you, sir. So then you talked about the pathogenesis, and classically we know it is the inhalation of a large load or especially virulent organisms which causes pneumonia. But now we also know that the lung as such is not sterile; it has its own microbiota. So how important is the microbiota? Without inhalation of organisms, can disturbances in the microbiota due to various host factors like change in nutrition, change in immunity, or something like that itself lead to pneumonias? What exactly is happening?
Well, what we are observing is that the normal microbiota changes to abnormal microbiota in a lot of circumstances. Okay? So the abnormal microbiota is impairing immunity, local and systemic immunity, and predisposing the individual for infections. So it is important to preserve the normal microbiota. One thing that we could do, and I didn't show to you, but I had two slides on that. There is clinical information now that we should try to avoid anti-anaerobic treatment because anaerobes that are the normal anaerobes of the lung are protective and form part of the microbiome of the lung. And both in the outside the hospital, for example, giving amoxicillin clavulanate or ampicillin sulbactam very frequently to COPD patients, for example, or in the hospital using antibiotics that kill the anaerobes, this can be followed by worse outcomes in severe patients, as it has been shown in uh, epidemiological studies. So now the concept is that the anaerobes are causing very few infections, in fact, and probably you need to cover a very specific ones. But this behavior of giving to the majority of the patients, for example, when they are in the ICU, piperacillin tazobactam, no? This is one of the anti-anaerobics antibiotics. We should review our guidelines for antibiotics. In the new guidelines about everything, this concept is not included, except in the 2019 community-acquired pneumonias guidelines, ATS, IDSAs, they said that don't use anti-anaerobics in patients with suspicion of aspiration, except if they have abscess or empyema.
Thank you, sir. So then just the last couple of questions. We have a normal respiratory flora, right? So which is very well described. Normal respiratory flora. And if you get that in a respiratory sample, you know it's a respiratory flora. But supposing you're getting mycoplasma or legionella from the flora, can this also be occasionally be part of the normal flora?
Uh, Legionella, no. It's mycoplasma. It is described in some microbiome studies, but no. The etiopathogenesis of these microorganisms is by inhalation,
Yes, sir. Okay.
not from colonization to infection. Okay.
Right, sir. Thank you. So the final question then is about the increasing use of lung ultrasound, sir. So now, sir, you have gone through several decades of pulmonary critical care, right? And you are grounded in classical teaching. So there's a major educational and cultural shift in critical care in pulmonology with a massive rise of point of care ultrasound and many modern ICU clinicians, particularly those from non-pulmonary backgrounds, increasingly rely on ultrasound for the rapid diagnosis of pneumonia and other pulmonary conditions. So while this is fast, some may worry it creates a superficial approach that bypasses deep classical understanding of pulmonary pathology, physiology, and detailed X-ray and CT interpretation. So you are a master of traditional respiratory medicine who has witnessed this and who's witnessing this technological shift. So, what is the right path forward for training the incoming generation of intensivists and pulmonary critical care people? Should we embrace ultrasound as a primary diagnostic tool, or should we go on with the classic teaching?
No, I think that the advantages of using ultrasounds are a lot. And one is a bedside device that you can diagnose pneumonia, but the problem is the skills. If the people are not well formed, for example, it is my case. I am not good using ultrasound to detect pneumonia, but if there is a well-defined teaching of the different specialists, for example, at the emergency department and at the intensive care unit, then yes. But if not, the ultrasound cannot be performed by people without experience because then the conclusions will be misleading. You understand? I am in favor of ultrasound use because it has a lot of advantages. You don't have to move to the patient to the CT scan room. The simple chest X-rays are really misleading in mechanically ventilated patients. So I am in favor.
Thank you, sir. That was the final question. Thank you very much, Professor Torres, sir. It was a very exciting, interesting, and educational lecture and the discussion. Thank you very much, sir.
Thank you very much. Have a nice day.
Thank you. And thank the audience for joining in. I hope you had some great learning. We shall put this up on our YouTube channel soon. Thank you very much. Good night to everybody. Good night, Professor Torres, sir.
Good night. Good night.